So Dr. Ravi Joshi couldn't make it today, so Dr. Gary Monteiro is going to be presenting anesthesia for lung transplantation.
As she just said, I'm not Dr. Joshi, and I'm not from UT Southwestern. I'm Gary Monteiro, and I'm from here at Houston Methodist. I got these slides last night. They're pretty good, so I figured I'd just go with it instead of trying to write a PowerPoint in the middle of the night. So lung transplantation, quick introduction. We're taking out one or both of the patient's lungs. This definitive treatment started conceptually in, 1962. University of Mississippi, then heart-lung transplantation in 81. First successful lung, 83 in Toronto. And there's a lot of lung transplants that have been done, about 42,000. Some quick statistics, there's about 3,000 lung transplant recipients waiting. And we do about 2,000 a year. Most of them, this thing wants to keep going forward. Most of them are bilateral. Medium time when you get posted for or listed for lung transplants, about 2 months. The age of the recipients is going up, and there's an increase in the recipients that are being listed with restrictive lung disease. And the thing to notice versus other transplants is that the survival for lung transplants is significantly less. About 50% are still alive at 5 years. This is in great contrast to hearts and in huge contrast to kidneys. Donor criteria, pretty self-explanatory. You don't want super old lungs. You don't want to transplant lungs that have pre-existing pulmonary disease. You want to have lungs that don't have any fungal in their stain. You want them to have a good PF ratio, an indicator of oxygen exchange. Different institutions do that different ways. ABGs versus pulmonary vein gases. Size matching is important. There's a couple slides on that later. You don't want to put huge lungs into a small patient, and you don't want to put tiny lungs into a large patient. Different institutions size their lungs differently, whether it's chest x-ray, AP, or total lung volumes, and then different donors. So to need a lung transplant, the general criteria are that you're going to die without a lung transplantation. We want a patient who doesn't have multi-organ disease so that their chance of survival post-transplant is high. And then the concept of 80% chance of 5-year survival in the absence of graft dysfunction. So there's basically four types of patients that are posted for lung transplants: obstructive lung disease, pulmonary vascular disease, which includes primary pulmonary hypertension, and then chronic embolic disease, CF patients, and then restrictive patients. Contraindications are malignancy, multi-organ dysfunction or other organ dysfunction, morbid obesity, atherosclerotic disease. We've done a couple of CABs in patients posted for lung transplants. Infections, chest wall deformity that would impair the transplant surgery. Relative contraindications, number 2 I'm going to say is not that big of a deal since we do that all the time. Patients getting transplanted off of particularly VV ECMO to lung transplantations happens at selected centers around the country, including ours. Really old patients and patients who have hepatitis, HIV. So anesthesia evaluation of patients coming for a lung transplant. Number 1, airway, most important, right? Typically these patients are on some form of oxygen supplementation. If they're coming from home, they're usually on nasal cannula. We want to know if the patient will be able to tolerate induction and airway manipulation. Will the patient be able to survive an extended period of one lung ventilation? Most important for induction, circulation. What's the function of the RV? What's the function of the LV? How is induction, one lung ventilation, pulling the heart side to side as we do our anastomosis, left atrial clamping going to affect their hemodynamics? And then are there any specific disease issues that I need to address in my recipient patient? Are they a scleroderma patient with Raynaud's? Maybe I won't put in a radial ALAN, maybe we'll go straight to femoral ALANs. Are they a CF patient where they're going to have a huge amount of secretions. Maybe I won't put in that 35 or smaller double lumen tube at the beginning. I'll just put in a single lumen tube, clean them out, switch it out. Are they a difficult airway? In patients going for lung transplantation, mucking around with the airway to put a double lumen tube in at the expense of their hemodynamics during the induction period, probably not that wise, because then you'll be coating a patient without an airway. So an airway is an airway. Get a single lumen tube in, it's way easier to exchange it for a double lumen tube. That way you can make sure they tolerate the induction. And the primary thing with induction is not just your agents, it's the switch from negative pressure ventilation to positive pressure ventilation. So if your first breath that you give in this little CF girl, who's 35 kilos, you squeeze the bag and give her 1.5 liters breath, she's not going to do that great. So make sure that your tidal volumes on your machine preemptively are turned down low, and you can always bring them up as they tolerate your peak and plateau pressures. Airway anatomy. These patients, a lot of them have had multiple bronchs before. A lot of them have been intubated before. So you always want to see if you can find the notes. Double lumen tube versus bronchial blocker. Most cases are done with double lumen tubes, or if you know you're going on bypass, single lumen tubes. Review the CT scans, look for any deviation. Here's just a pre-op VQ scan in the sense that, is this patient going to tolerate an off-pump double lung or a single lung? Looking at the ventilation perfusion of each lung. These are always in the pre-op workups. PFTs, they suck. You're not going to be doing a lung transplant and somebody has good PFTs. In these patients, it doesn't necessarily alter the anesthetic plan. You're going to pre-oxygenate them very well. You're not going to let these patients move over the table like Jason said. If they move over from the bed to the table, you're going to spend 20 minutes waiting for them to catch their breath while the lung's in the airplane. So you just lost 20 minutes. So you move them, you pre-oxygenate them, you let them sit up, and then you let them get comfortable and be on 100%. Cardiac evaluation. What we care about in lung transplantation particularly is right ventricular function. The reason is because we're going to clamp a PA. We're going to clamp a branch PA. So if we were doing plumbing, we're going to double the flow through the opposite vascular tree. And theoretically, we're going to increase the pressures on the right heart, or double them. So if you have an already struggling RV, it's not going to tolerate PA clamping. So we want to know what RV function is. You can pretty much tell from the echo right after you induce the patient and from the PA pressures whether they'll tolerate an off-pump double lung. Before the surgery starts after induction is your small frame, your small window to optimize that patient. Whether that's optimizing oxygen, CO2, starting them on inotrope, starting them on pulmonary vasodilators. It's up to you, but you can tell right away whether the patient will tolerate a pulmonary cross clamp. Coronary artery disease is right there at the bottom also. Okay, cardiac evaluation. There's an echo of a heart, okay. All these patients have had heart caths, and we're particularly interested in their pulmonary vascular resistance. If they did pulmonary vasodilator testing in the lab, starting nitric oxide on somebody who's pulmonary vasodilator unresponsive is just giving money to the nitric oxide company. Typically in the lab, we'll cath these patients, we'll look at their pulmonary pressures, then we'll put them on 100% oxygen, plus or minus nitric oxide, and see if not their pulmonary pressures come down, but if their pulmonary vascular resistance as calculated comes down. So in the preoperative reports, you'll always have a sense of whether the the recipient's responsive. Stress testing, global, all the normal preoperative workup. You will apply standard ASA monitors. That's like your oral boards. So standard ASA monitors, invasive blood pressure monitoring. Typically for single lungs, we just place a radial line. A lot of times for the double lungs, we'll place a femoral line also. Don't make the mistake of putting your femoral line in the upper leg that your surgeon, that'll be available for your surgeon. Always put it in the lower leg. PA catheter, TE, cerebral oximetry, defibrillator pads, all the sort of straightforward stuff. The caveats to, it'll be on their lines, access, here you go. So typically we place a right IJ or left IJ, a cordis, PA catheter. I'm not a stickler about large bore IV access times 2. That's at their institution, they like to do that because we have a cordis, A-lines. The caveat is if you're bringing a patient to the OR who's on VV ECMO, or if they're on a Protect catheter, your right IJ is already occupied. So a lot of these patients, particularly ECMO patients, you need to sort of sometimes be creative with where you put your lines. Like Jason already hinted at, induction is the time for cardiovascular collapse. Things you need to think about, number 1, tension pneumothorax. When you switch to positive pressure ventilation, if it's a patient that has blebs. Induce them very slowly. Most of them will go to sleep with a warm blanket. These people, once they feel that they're not drowning from the lack of being able to breathe, they'll fall asleep. So we're talking 10, 20 propofol, they're asleep. Always optimize your pre-oxygenation. Don't muck around with the airway. Don't force a double lumen tube at the expense of CO2 and oxygen. Lung hyperinflation, just small tidal volumes, and then watch the RV. Maintain blood pressure. This is why we care about pulmonary arterial hypertension and RV pressures. A lot of these patients have elevated RV pressures, which sacrifices their coronary perfusion. So you always need to be thinking in patients for lung transplant, or in particular, pulmonary hypertension patients, how am I maintaining coronary perfusion to the right heart? Pulmonary pressures, RSI. There's some people assume all these patients are full stomachs because they're coming in sort of last minute. And then he listed some induction schemes. One lung ventilation, smaller tidal volumes, good PEEP. We're gonna struggle, of course, to keep these patients sats up most of the time. Low peak pressures, tolerate some hypercapnia. A little bit of hypercapnia never killed anybody, especially since all these patients are hypercapnic at baseline anyway. Pulmonary vasodilators, 2 main flavors that we use in the OR are nitric oxide and Flolan. Depends on your institution, cost. The only caveat is some anesthesia machines can deliver one, they can't deliver the other, so you may be on a ICU ventilator. Flolan is sticky, so it'll gunk up your HME, and if you don't put a filter on it going into the machine, it'll make your expiratory valve sticky and break the machine. Those expiratory valves are really expensive. I know because I did it. Immunosuppression. They'll get some dose of steroid depending on your institution. They'll get some induction agent, either rabithymo or basiliximab. What's this one? Okay, so when to go on bypass. So you're doing a lung transplant, double lung, the plans to, single lungs rarely, if ever, go on mechanical support for the operation. So you're doing a double lung, you're planning on doing it off pump. The RV looked good, the pressures were okay. I typically look for a systolic blood pressure ratio to PA pressure ratio of greater than 2 to 1, knowing that we're gonna be clamping the PA and I wanna maintain coronary perfusion. So I'll try to bring down the pulmonary pressures, bring up the systemic pressures before we clamp. But they test clamp the PA, you're looking on your echo, the RV wall blows out and starts to dilate. That's an indication for mechanical support. The lack of being able to exchange gas, you can't oxygenate, you can't blow off CO2, that's an indication for bypass and RV failure. Fluid management, like most thoracic surgery, we don't want to give them a ton of fluids. Some institutions, there's no colloid in lung transplantations. Other institutions, it's more liberal. Greater than 5 liters of fluid in the first 24 hours post-lung transplants associated with primary graft dysfunction. Most institutions have some protocol they follow to limit fluids, diuretics, vasopressors. He says avoid blood products. I'd say that's institutional. Some places are very quick to use red blood cells for volume expansion. You're gonna clamp the PA with a little heparin. Sometimes your hemodynamics get a little wonky because the RV is not used to that increase in afterload. You should have already optimized the patient. You're not You don't have time, and it's not the appropriate time to clamp the PA and then try to fix the RV. You should fix the RV before you clamp the PA. Inotropes vary by institution. Unclamp the PA, pressures go down, just like when you unclamp anything. This can be due to preload going down because you're filling the lung, which is a sponge. It can be due to washout, whatever. But the take-home message is there's some data to suggest that when you reperfuse the lung, you want to have as low as possible of FiO2, and that it decreases primary graft dysfunction. Particularly if you're on pump, this is easy. If you're doing an off-pump double on a patient that's pretty marginal, if you're not on 100% oxygen, their SATs are down in the 80s, you cut them down to 30%, they're going to be a little lower. So it all just depends on how much you can tolerate, you're comfortable with. Lots of things can happen when you unclamp. You can see EKG changes. Sometimes it's air, sometimes it's just changes in coronary perfusion pressures across the heart. Acute lung reperfusion injury. Pulmonary vein occlusion is pretty rare, especially when the chest is still open. And as part of our post-operative exam, we're always going to look at the pulmonary vein flow. Poor gas exchange, we're gonna play with FiO2 and PEEP. If you're struggling post-lung transplant with your gas exchange, go on mechanical support and rest the lungs. Decreased compliance, not as common anymore that the donor lung would require really high peak pressures. Ventilation of the transplanted lungs, smaller tidal volumes, good PEEP. You don't want overextended lungs, you don't want underfilled lungs. This is usually through visual inspection, just with you and your surgeon. Maintain adequate SATs, not perfect SATs. Remember, the enemy of good is better. Like if you're pursuing, try to make the patient perfect, it's not gonna happen. You can't polish a turd into a diamond. So you want adequate, you want aerobic metabolism. Aerobic metabolism doesn't need 100% oxygen most of the time. Also permissive hypercapnia, and then suction the lungs because there'll often be debris from the surgery. TEE, super useful in lung transplantation, looking at RV function. You want to rule out any intracardiac shunt that later on could confuse the picture of if the patient's hypoxic. And then post-op, we always look at the pulmonary veins to make sure that they're not obstructive. We're looking for laminar flow, a nice juicy diameter, and low velocities, less than 1 meter a second. Some places will tolerate up to 1.5 meters. Primary graft dysfunction, just a quick slide because I'm run out of time here. It's graded. It's failure to oxygenate clearly when you have increasing levels of FiO2. And it's pretty common. Risk factors, this is the big thing. And you can see the ones that are under the control of anesthesia are the FiO2 at reperfusion. And if you're struggling, go on bypass for the procedure or go on ECMO, depending on your institutional preference for what you use for the procedure. But mechanical support is associated with this somewhat increase in primary graft dysfunction postoperatively. And then this is the last slide, and this very much varies by institution and your protocols. I've been at institutions where we put thoracic epidurals in every single one. They breathe better, they clear secretions better. Some places place them postoperatively right before extubation. I've done them with thoracic epidurals, paravertebral blocks, erector spinae blocks, intercostal blocks, and I think of them more as an adjunct for these patients. We currently don't place them, and we just do expiral infiltration. I think it works pretty well. Well, there you go. And I'm Dr. Joshi.